Welcome to the Deep Dive. We cut through the noise to bring you the critical insights you really need.
Great to be here.
Today, we're tackling something pretty serious. Anaphylaxis. That sudden, scary health crisis that can go from zero to life-threatening in, well, minutes?
It really can. Anaphylaxis isn't just, a bad allergic reaction. It's a full-body, systemic hypersensitivity reaction. And yes, it can be fatal. It's a true medical emergency.
Absolutely. And our mission for this deep dive is to pull together the latest thinking from the big international players we're talking, the European Academy of Allergy and Clinical Immunology, the World Allergy Organization, the UK's Resuscitation Council.
Basically synthesizing those key guidelines.
Exactly. We want to extract the absolute must-knows about spotting it, managing it, and maybe even preventing it, arming you with knowledge that could genuinely save a life.
And there's some surprising aspects, things people might not realize.
Like what?
Well, despite its potential severity, the actual fatality rate overall is relatively low, which is good news, of course. But interestingly, hospitalizations for anaphylaxis have been going up quite significantly.
So more cases or maybe just better recognition?
Could be either, or both. It's something researchers are looking into.
And here's something that really caught my eye. That classic picture of anaphylaxis, the hives, the swelling. It doesn't always happen.
That's a huge point. Up to 20%, maybe 1 in 5 severe cases, might not have those obvious skin symptoms at all.
Wow, that makes recognizing it so much harder.
It really does. So yeah, this deep dive should help clarify those crucial details.
Okay, let's dive in, starting with the basics. What is anaphylaxis fundamentally? Why is it such an emergency?
The key is that word systemic. It's not localized. It's a rapid body-wide overreaction that hits multiple organ systems. That's what makes it so dangerous so quickly. It's the system going into overdrive.
And when you say rapid, how rapid are we talking?
Usually symptoms kick in within minutes of being exposed to the trigger.
Yeah.
That speed is a hallmark.
Minutes, okay.
Though it's worth mentioning there are some exceptions, like alpha-gal allergy, the red meat allergy from tick bites. That can have a delayed onset, sometimes hours later, which presents its own challenges.
Right, so usually fast, and often we see those skin signs, hives, itching, flushing, maybe swollen lips or tongue. You said those are common.
Oh, very common.
That's...
Skin and mucosal symptoms, think mouth, throat, they show up in over 90% of cases. They're definitely a major clue.
And this is the crucial bit. You mentioned they're not the whole story.
Exactly, because the really life-threatening stuff often involves breathing or circulation. Difficulty breathing, wheezing, a sudden drop in blood pressure, even collapse. Those happen in over half the cases.
Over 50%.
Yes. And relying only on seeing a rash or swelling means you could miss a severe reaction unfolding internally.
So that common idea, no rash, no anaphylaxis, is just wrong.
Fundamentally wrong.
Yeah.
And dangerously so. The guidelines are very clear. Those typical skin signs can be subtle or completely absent in 10, maybe 20% of severe reactions.
Which means, for you listening, understanding this variability is key. You've got to look beyond the obvious skin stuff for those breathing or circulation problems. That's the hurdle, right? Recognizing it early enough.
That's often the biggest challenge to getting the right treatment quickly.
Okay. So, we know what to look for, broadly speaking. What are the usual suspects? What actually triggers these reactions?
Well, the big 3 categories are generally foods, drugs, and insect venoms. But what's really interesting is how much it varies.
Varies how?
By age and definitely by where you are in the world. So for kids, you often see reactions to things like peanut, hazelnut, milk, egg, pretty common allergens.
Right.
But for adults, say in Europe, it might be more commonly wheat, celery, shellfish. Go somewhere like Spain or Italy, and fruits like peaches become significant triggers.
Right. Wow.
Yeah. Or sesame in the Middle East. Buckwheat's a big one in Korea. It really reflects local diets and environments.
Fascinating. And insect venoms?
Again, depends where you are. Wasp and bee are common in Europe. But you've got fire ants in parts of the Americas, Asia, Australia. Even reactions to snakebite antivenom itself can happen.
And drugs?
Antibiotics are a frequent cause, especially a group called beta-lactams. Penicillin is in that group. Also, NSAIDs, non-steroidal anti-inflammatories like ibuprofen.
Okay.
And if you're looking at reactions during surgery in that perioperative setting, antibiotics again, and also the drugs used for muscle relaxation, the neuromuscular blocking agents, they're leading culprits.
So it's not just about if you're exposed, but sometimes how bad the reaction is can depend on other things. These cofactors.
Ah, yes, cofactors. This is really important. These are things that don't cause the allergy themselves, but they can sort of lower the threshold for a reaction or make it much worse when it happens.
Like what sort of things?
Things like exercise is a big one. Physical exertion around the time of exposure. Also, stress, having an infection, drinking alcohol, even taking other meds like those NSAIDs we mentioned.
So managing risk isn't just avoiding the trigger, it's also being aware of these amplifiers.
Exactly. Amplifiers is a good way to put it. Context matters.
Are we still finding new triggers?
Absolutely. Medicine evolves. We're seeing reactions to newer types of drugs like certain biologics used in cancer or autoimmune treatments. Even things like disinfectants, chlorhexidine is one, particularly in hospitals or clinics.
Huh.
And then there's the really tricky category, idiopathic anaphylaxis, meaning we just can't find a clear cause, despite extensive testing. And that accounts for a surprising number, maybe anywhere from 6.5% up to 35% of cases in some studies. It really shows how complex this can be.
Definitely complex. So given all that potential variation, how do doctors or even first responders diagnose it confidently in the heat of the moment? What are the criteria?
It really comes down to looking for that rapid onset of symptoms involving multiple body systems. The guidelines lay out a few clinical scenarios. Scenario 1, sudden illness, minutes to hours with skin or mucosal involvement, the hives, itching, swelling we talked about, plus at least one of the following. Respiratory compromise, trouble breathing, wheeze, low oxygen or reduced blood pressure, feeling faint, collapsing.
So skin plus breathing or circulation issues.
Precisely. Scenario 2, you see 2 or more of the following happening quickly after someone's likely been exposed to an allergen for them. Skin mucosal signs, respiratory compromise, reduced blood pressure, or persistent severe gastrointestinal symptoms. Think bad cramps, repeated vomiting.
GI symptoms too. Interesting.
Yes, they can be part of the picture. And scenario 3 is simpler. If someone is exposed to an allergen they know they react to, and they suddenly develop low blood pressure or collapse, that alone is enough to diagnose anaphylaxis.
Got it. Now, this is critical. How do you tell it apart from other things that might look similar, like someone just fainting or maybe panic attack? Seconds count.
That's a huge challenge in practice. A simple faint, what we call a vasovagal episode, is usually very sudden, but they often recover quickly once they lie down flat.
Okay.
Key differences. Fainting usually involves a slow heart rate, and the person looks pale. Anaphylaxis typically has a fast heart rate, though it can slow down late in severe cases, and the skin is often flushed, maybe with hives. If someone faints and doesn't recover quickly when lying down, you absolutely have to suspect anaphylaxis.
Right, and panic attacks.
They can feel terrifying, that sense of doom, shortness of breath. But typically, you don't see the objective signs of airway swelling, wheezing, low blood pressure, or those skin changes like hives. It's more subjective feelings versus objective physical signs.
That makes sense.
And it's worth mentioning again, especially with kids, severe asthma can look very similar to the respiratory signs of anaphylaxis. So if there's any doubt an anaphylaxis is suspected, the advice is to give adrenaline promptly. Don't delay.
Okay. What about blood tests? I've heard of something called tryptase. Is that used right away?
No, absolutely not for the immediate diagnosis or treatment. Tryptase is a substance released by mast cells during some allergic reactions. Measuring it in the blood can help confirm a diagnosis after the event, when you're following up with an allergy specialist.
So it's a retrospective tool.
Exactly. Ideally, you draw blood samples between about half an hour and 2 hours after the reaction starts, and then a baseline sample much later, like 24 hours after everything's settled down. But the absolute key point, testing for tryptase must never, ever delay giving emergency treatment, especially adrenaline.
Okay.
And also, a normal tryptase level doesn't rule out anaphylaxis.
Right.
Especially in kids, or if the trigger was a food. It's just one piece of the puzzle looked at later.
Right. So diagnosis is clinical, based on those rapid multisystem signs. Once you suspect it, what's the number one thing to do, the immediate lifeline?
Adrenaline, also known as epinephrine. It is the absolute, unquestionable first-line treatment.
Get it in fast.
Promptly. And the recommended route is intramuscular injection IM straight into the mid-outer thigh muscle.
Why intramuscular? Why not under the skin or inhaled?
Good question. IM is proven safer and more effective for anaphylaxis than subcutaneous injection.
Yeah.
Gets absorbed faster and more reliably. Doesn't need IV access, which takes time, and it's relatively easy for patients or caregivers to learn how to do it correctly.
Okay, IM mid-thigh. What about the dose?
It's crucial to get the dose right, and it depends on age and, to some extent, weight. For adults and kids over 12, it's generally 500 micrograms.
Okay.
For children aged 6 to 12, it's 300 micrograms. Younger kids, say 6 months up to 6 years, it's 150 micrograms. And for infants under 6 months, it's usually around 100 to 150 micrograms based on weight.
And what if the first dose doesn't seem to work?
That's a critical point. If there's no significant improvement in breathing or circulation symptoms after about 5 minutes, the guidelines strongly recommend giving a second IM dose of adrenaline.
Which is where adrenaline autoinjectors, AAIs, come in, right? The EpiPens and similar devices.
Exactly. They are vital for people at risk, allowing them or a caregiver to give that first dose quickly in the community before emergency services even arrive.
But I hear there are different types.
Yes, and this is important. Training needs to be specific to the device the person carries because they work slightly differently. And another key insight. Studies show different brands can deliver adrenaline into the bloodstream at different rates and levels. They're not considered interchangeable.
Interesting. So you can't just swap brands easily.
You shouldn't without specific advice.
Yeah.
And because of the potential need for that second dose, the European Medicines Agency actually recommends that patients at risk carry 2 AIs with them at all times.
2 devices.
Okay.
Now, besides the adrenaline itself, you mentioned posture is really important.
Hugely important. It can genuinely be life-saving. If the person is showing signs of low blood pressure, feeling faint, dizzy, weak, the best position is lying flat with their legs elevated.
How does that help?
It helps maximize blood flow back to the heart and up to the brain. Simple gravity.
Makes sense. What if breathing is the main problem?
If it's mainly respiratory distress, they might feel more comfortable sitting up slightly, kind of semi-recumbent. But if possible, still try to keep their legs elevated.
And pregnant patients?
They should be positioned on their left side, ideally with the bed tilted slightly head down if possible. This helps prevent the uterus compressing major blood vessels.
And the big don't.
Don't let them suddenly stand up or sit up quickly. Fatalities have happened when someone experiencing anaphylaxis suddenly changes posture to be upright. Keep them lying down or in that supported semi-sitting position.
That's a really vital practical tip. What about IV adrenaline? You hear about that in hospitals.
Intravenous adrenaline is definitely used, but it's strictly for experienced healthcare professionals in a monitored setting, like an emergency department or an ICU, or for cases that aren't responding to the IM doses, what we call refractory anaphylaxis.
Well, only in those settings.
Because giving adrenaline IV carries significant risks if the dose or rate isn't precisely controlled.
Yeah.
It can cause dangerous heart rhythm problems or severe high blood pressure. It's not for first-line use outside of that expert environment.
Okay, so adrenaline IM first. What else helps? What are the key supportive measures? You mentioned oxygen.
Yes, high-flow oxygen should be given as soon as it's available, aiming for oxygen saturation levels between 94 and 98%.
And fluids.
Intravenous fluids are absolutely crucial, especially if there's low blood pressure or the person isn't responding well to the initial adrenaline. We give rapid pushes or boluses of crystalloid fluids, basically saltwater solutions.
How much fluid?
It can be a lot. In adults, maybe starting with 500 to 1,000 milliliters quickly. For kids, it's weight-based, often around 10 milliliters per kilogram. But in severe shock, an adult might need several liters of fluid.
Why so much?
Because during anaphylaxis, the blood vessels become leaky. A huge amount of fluid, maybe up to a third of the circulating blood volume, can shift out of the blood vessels into the tissues.
Yeah.
This third spacing causes the blood pressure to plummet. Fluids help refill the tank, so to speak.
Right. So if someone has had 2 IM adrenaline doses and is still doing poorly, that's refractory anaphylaxis. What happens then?
That's an immediate escalation. Get them to critical care or bring critical care expertise to them. The next step is usually a continuous intravenous infusion of adrenaline, managed very carefully by experienced teams.
Okay. Now let's talk about other meds often linked with allergies. Antihistamines, steroids. Where do they fit in the acute emergency?
This is where there's often confusion. Let's take antihistamines first. They can help with the skin symptoms, the itching, the hives.
So they do something.
For the skin, yes. But they have no effect on the life-threatening respiratory or cardiovascular problems, the breathing difficulties, the low blood pressure. Absolutely none.
So not a replacement for adrenaline.
Not even close. And critically, giving antihistamines must never delay giving adrenaline. Adrenaline first, always. Antihistamines are, at best, a secondary treatment for skin comfort later.
Okay. What about corticosteroids, like prednisone?
Steroids are also not recommended for the immediate acute emergency treatment. There's a historical thought that they might help prevent the reaction from dragging on or prevent a biphasic reaction. We'll come back to that. But the evidence supporting this is actually very weak, rated as low certainty.
So not a priority.
Definitely not a priority over adrenaline and fluids. Some studies even hint that giving steroids very early might, counterintuitively, be associated with a higher risk of needing ICU admission, though more research is needed there. Bottom line, don't reach for steroids first in an acute crisis.
What about inhalers, like asthma inhalers?
Things like salbutamol inhalers can be useful if wheezing or bronchial obstruction is a major feature, but only as an adjunct and add-on to adrenaline, never as a substitute. Adrenaline treats the whole systemic reaction. The inhaler just helps open the airways a bit.
And there was one other drug mentioned, glucagon.
Yes, glucagon is a consideration, but only in a very specific situation. Patients who are on beta blocker medication, often used for heart conditions or high blood pressure, and who aren't responding well to adrenaline. Beta blockers can sometimes interfere with adrenaline's effects, and glucagon works via a different pathway. But again, this is more specialist territory.
So the hierarchy is clear. Adrenaline first and foremost, supported by oxygen, positioning, and fluids. Other meds have very limited specific roles in the acute phase.
That's the core message from the guidelines.
Okay, let's think beyond the immediate crisis. The person has been treated, symptoms are improving. What happens next? Do they just go home?
Not usually right away. Observation is really important because of the risk of a biphasic reaction.
Biphasic, meaning?
Meaning the symptoms can come back, they resolve initially, and then hours later they return, sometimes just as severely without any further exposure to the trigger.
How often does that happen?
Estimates vary, but it's thought to occur in around 5% of anaphylaxis cases. The timing is also variable, but the median onset seems to be around 10 to 12 hours after the initial reaction started.
Are some people more at risk for this?
Yes. Factors that seem to increase the risk include having a very severe initial reaction, needing more than one dose of adrenaline, or if there was a delay in getting that first adrenaline dose.
So how long do people need to be observed?
It depends on those risk factors. It's a risk-stratified approach. Someone with a mild reaction that resolved quickly with just one AAI dose might only need observation for, say, 2 hours.
Okay.
But someone with a more severe reaction, or who needed multiple doses, or has underlying asthma, or presented late to medical care, they might need observation for 6 hours or even 12 to 24 hours to be safe.
Yeah.
You can't just assume you're clear once the initial symptoms fade.
That's really good to know. Beyond that observation window, what's the long-term plan for someone who's had anaphylaxis?
Long-term management is crucial to prevent future episodes or manage them better if they occur. The first essential step is referral to an allergy specialist.
Why is that so important?
To try and confirm the trigger, assess the ongoing risk accurately, and develop a personalized, comprehensive management plan. That plan should include a written emergency action plan.
What's in that?
Clear instructions. What specific allergens to avoid, how to recognize the symptoms of a reaction early, and exactly when and how to use their adrenaline auto-injector. It needs to be crystal clear.
And training.
Absolutely vital. Proper structured training on how to use the specific AEI device they have and on the emergency steps. This isn't just for the patient, but also for family, caregivers, school staff, anyone who might need help. Confidence comes from competence.
What about things like medical alert bracelets?
Yes, medical identification like bracelets or necklaces, or even using the in case of emergency features on smartphones. It'd be really helpful to alert responders about the allergy if the person can't communicate.
And for kids in school?
Schools need clear anaphylaxis policies and trained staff. The guidelines strongly recommend this to create a safer environment, though more research is actually needed on the best ways to implement these policies effectively.
It sounds like education and preparedness are key across the board, even for healthcare professionals themselves.
Definitely. Things like simulation training, using realistic scenarios, and having visual aids like flowcharts or wallet cards readily available were all suggested ways to help healthcare providers recognize and manage anaphylaxis quickly and correctly. It's about constant reinforcement.
Looking at all these guidelines, what's the biggest takeaway for you, or maybe the biggest challenge still remaining?
You know, despite having these detailed guidelines from expert groups, it's quite striking when you dig into the evidence behind them. For many of the recommendations, the underlying evidence is graded as very low certainty.
Really? Even for things like adrenaline?
Adrenaline's effectiveness is well established, but for aspects like optimal dosing in certain groups, the exact role of steroids, the best observation times, The high-quality trial data just isn't always there. It highlights a real need for more robust research, better clinical trials, maybe better diagnostic markers than just tryptase, more studies on the best educational strategies.
So we have best practices based on current understanding, but there's still a lot to learn.
Precisely. We need to keep refining our approach based on better evidence as it emerges.
Well, this has been incredibly insightful. We've covered a huge amount today, from really understanding what anaphylaxis is, how varied it can look, the absolute primacy of adrenaline, the more limited role of other meds, and the crucial need for ongoing vigilance, education, and personalized plans. It's clear that knowledge and preparedness here aren't just useful, they're potentially life-saving.
Absolutely. It's about being empowered to act decisively.
So here's a final thought to leave you with. Given that variability in presentation we discussed, and the fact that so much of the current management relies on evidence that's, well, maybe not as strong as we'd like.
Yeah, that very low certainty point.
Right. How might things change in the future? Could we imagine a time where maybe personalized, real-time diagnostic tools, perhaps wearable sensors or rapid biomarker tests, could instantly tell someone or a first responder not just if it's anaphylaxis, but maybe predict its severity or guide the specific treatment needed for that individual in that moment?
Moving beyond the current sort of best guess protocols to something truly data-driven and personalized in the heat of the moment, that would be a game changer.
What more could we do, perhaps, to empower every single person at risk, every family, every healthcare provider, to act with even greater confidence and precision than we can today? Something to think about.